So what I like to do is make sure tonight event is memorable, and we answer all the questions who have asked us to on this panel. We still have most of the people who are watching us. So one question which everybody asking is that if specialists can create their own ACO and able to do same thing what the ordinary primary care ACO do. Who will take their question? So David, you want to take the question or anybody else? Dr. Arthur Henson,
Dr.
you
Hanson,
want to take
please.
the question? Can specialists can create their own ACO?
An MSSP program would be very, very hard for a specialist to start on their own. Just by the nature of the assignment, it's highly favorable to be the patients to be assigned to the primary care physician, almost 10 to 1 benefit easier. Thus, my short answer is no. But can they participate in a primary care ACO? That is the best formula for specialists to join a primary care or any ACO. It doesn't have to be labeled primary care. And if they have assigned lives, in what we do is we treat them. We have a formula that treats them extremely beneficial when they do have assigned lives for that. You know, this is a program that's built on cooperation. You know, you've been successful, Dr. Agrawal, and Doctors ACO, as we have in Palm Beach, and Lou in Citrus County, of course, is through cooperation with specialists. We need specialists to keep this program successful. So they're part of it. It's not like an HMO plan where we have authorizations and referrals. So the best formula is for them to join an ACO and participate actively in it, beneficially, mutually beneficially.
Thank you, Dr. Henson. So I'm going to let people who raised their hand. One is Dr. Asha Parikh. See, I'm going to allow you, so go ahead and speak. Okay, so that didn't work. Let me ask you, I'm looking at the questions, and the question was what it takes to start a Advantage Care plan in Georgia. So you asked us that, Dr. Henson, and you told us what we need to do, a critical mass. And critical mass means we enough physician and specialist in a county to able to say, listen, we're going to take care of the beneficiary, Medicare beneficiary, and we are willing to put money into it to make it happen. So so in order to do that, we have basically realized in Georgia, things are different than in Florida, Palm Beach. We have an organized physician together. I think our ACO has physician was not enough. So we decided to start an IPA where the people from all the ACO can join, people from all the IPA can join, and then hopefully we can create a critical mass within the next 12 months. So we can start something like, we can invite you to come to our place and start talking about it. So Don, you are here? Don, tell us of what we have done with IPA so far.
So, hi, I'm Dawn Dobbs. We have developed the company for the IPA here in Athens. It's it's A1 Association, Doctors Association. We've created the group. We've gotten it registered, and we've also gotten it registered with the IRS with a tax ID, and currently working on the contracts for investors, non-investors, as well as the operating agreement. So hopefully all of that will be done by the end of this week.
Our goal is, and Dr. Parikh, what do you think? Our goal, we should invite Dr. Henson when? Maybe sometime in September, October, something like that. I think our goal is to give you what you need. I know what you need. You need a critical mass in a primary care physician who willing to take the patient and who going to learn the MRA scoring, who will able to work as a super doc for the Advantage Care plan, right? So I wanna have one more time. I want you to tell us what you really need to help us to create the Advantage plan in Georgia.
Well, I think you're on the right track. We need motivated doctors that are willing to invest in the plan. And the investment is not, a tremendous amount of money, but just enough for them to feel that they will take ownership of the plan. We find that we don't want to do a project in Georgia or anywhere unless it's going to be a home run. And a home run where the rainbow ends is going to be a large pot of gold. And we have resources to deploy, but we want to deploy the resources where we know everyone is going to win, and everybody believes it, and everybody has drank our Kool-Aid with the gin and tonic in it. That's going to make them all happy and believe in it. And that's what we're looking for. The most important thing that you guys are doing in Georgia is building a level of trust and transparency with your physicians. And that's what the Medicare Advantage plan is going to be. But there needs to be a belief in it. And the biggest challenge that happens, at least that we've faced here, is a lot of doctors are part of other Medicare Advantage plans, and they get a decent amount of income from it. So we're determined to prove that in our model, you'll eventually be getting minimal 25% more on that same patient just through our formula. We believe that there's that much fat that's going, minimal to the MSO, which is the middleman, or the advertisement, or the large administrative staffs, or the big fancy CEO at the top that makes so much money. So we're not holding services on our plan. We're just reallocating where the funds should go. And we believe once we're able to prove that here in Palm Beach, it's going to spread like wildfire, because now the doctors are getting hopefully 20 or 25% more per patient for the same service that they would get with a comparable plan. And most important, they're building disproportionate wealth in terms of equity in something that they own and is tangible, that they can give their grandchildren, et cetera, et cetera, et cetera. And it's a proven business model. ACOs are valuable, but it's not yet a proven business model for sale and equity and Wall Street, et cetera, et cetera. But Medicare Advantage plan is the holy grail. And you see the trajectories. I'm a huge believer in the future of ACOs, and I'm 100% in till the end. But I do see that the government is pushing Medicare Advantage plans a lot. And you saw in the beginning of my slides that the growth of Medicare Advantage plans are staggering, 34%, and it's going to keep going. And when it crosses 50%, that's a lot. The government wants to deal with less entities, and they would rather they think they can control the expenses by dealing with 2,000-3,000 Medicare Advantage plans as opposed to 1 million or 1.1 physician providers that they have to deal with. So
let me ask you another question this is from anonymous attendee. And it says, can we start an Advantage plan in an area without having a formal ACO?
Possibly. I mean, possibly, but you need to have a good number of doctors. It depends on the county. So Palm Beach County is a big county. It's one of the largest counties. It's the largest county east of the Mississippi. It's a big county and territory. And you need to have certain requirements in the county, meaning that a patient, has to be within 30 miles or 20 miles of every primary care, and it has to be within, 60 miles of any orthopedic surgeon. But there's a lot of those things that you have to meet. So it is possible to do one without an ACO, but it's best to have some level of vehicle that's organized. So if you have an IPA instead of an ACO somewhere where the doctors are organized, great. But to go knock on doors and asking doctors to recruit and building that level of trust and having them, feel and drink the Kool-Aid is going to be very, very hard. It's very hard.
So I just want to make
Doctor-
sure
Hi.
that
Hello?
what about this question comes from a, great friend of mine who really take care of kids. So he's saying, what about a pediatrician? Can they do something like that?
Not
May I
usually.
answer that?
Go ahead,
Or
Dr.
David?
Lane. No, you
So-
got it.
It's for Medicare fee for service patients. So in California, we actually have a pediatrician who has disabled children that are already on Medicare. So they do our part of the ACO assignment, but normally it's only for those eligible for Medicare fee for service. So if he treats those patients, yes, but if not, he wouldn't get any assignment.
Important question. This is my friends who are specialists in geriatric medicine, they think most of their patients are in Advantage plan. Is it really worth joining an ACO? David, you want to take that question?
Sure. So we have physicians that have mostly Medicare Advantage and geriatricians that's included, and they still usually have, 50 Medicare fee for service assigned patients. And the idea is there's no downside. So many physicians do well in Medicare Advantage, and many patients refuse to switch. So if you're in an ACO, you still get extra money for those patients that don't switch. So it's usually a good complement no matter what. Dr. Agarwal, can I comment on specialists? So Dr.
Sure.
Hansen is absolutely correct, is the ACO is really designed for PCPs and not specialists. But it's important to point out that over half of our ACOs were started by specialists. And the idea is the specialist was independent and they were concerned about the referral source being acquired by the hospital. So if the PCPs sell to the hospital and then the PCPs have to send to the hospital-owned specialists, the specialists were very concerned that their referral source was going to dry up. So what they did is, they're very unifying personalities. And what they did is they got the PCPs to work together and they got the PCPs to meet. And all you need to do is get 10 or 15 PCPs in your area to regularly meet, and you can start an ACO or you can start a pod. And once that specialist gets 15 PCPs earning $30,000 to $50,000 a year, guess what happens to that referral source? It is now very secure, and it's very secure for years to come. So, definitely specialists, if you can bring PCPs together, you can bring an ACO to your market, and it only takes 10 or 15.
So how can I switch from my current hospital?
Let me say one thing also about the question of the geriatrician that may have very few patients. David absolutely is correct. There's no downside risk. You should join, of course. But more importantly than just only for those 50 patients is you're part of a platform that is going to evolve and change. Our ACOs today may not look the same in 10, 15 years, but the government is utilizing our platforms and they're very fluid and they're going to continually change them only for the benefit. And our PBACO has changed in multiple things. And one of our key things that we changed in is we got into the commercial ACO business. As we manage 93,000 Medicare Advantage lives, we also manage 130,000 commercial lives for Blue Cross, Cigna, United, and other plans. But so now all of a sudden we need a pediatrician. Now all of a sudden we need more specialists for things. So you don't know where it's going to be, but if you participate in a matter with like-minded physicians that are organized, it can only be upside over time.
That's awesome.
Dr. Agarwal, there's one more question. It's
Sure.
asking about direct contracting. So
Yes, yeah, please do.
direct contracting entity is essentially an ACO. It has very similar aspects. It's actually a continuation of the next generation ACO program and the Pioneer ACO program. So it really is an ACO. And our group has 3 approved applications for direct contracting. And there's like a very small sliver of physicians that are guaranteed to do better in that program than the ACO. So right now, of our 11 ACOs, only one is going to convert to direct contracting. But what we do is we analyze all the rules. And if the physicians would do better in direct contracting, we'd happily switch. But it just doesn't look like that. So there's a very unique set of physicians that would do better. And otherwise, we're going to stick to the MSSP until the rules change. And we keep an eye out on that.
Hello,
Hi.
Dr. Rohit Desai.
Yeah, go ahead and ask questions.
My question for Dr. Henson, for an Advantage plan to be successful, how many patients we require?
Good question. I mean, and it's a difficult question because you can make money on 1,000 patients. You can make more money on 10,000 patients. Or you can make less money on 10,000 patients. It's a matter of the utilization of course, and the coding, of course. But naturally, the more patients, the better, as in any insurance plan. So it's hard to say. So we believe we have a plan that we're going to lose money for the first 2 years. And then we're hoping year 3 and 4 and 5 will have extremely good growth and success. And the other thing is with a Medicare Advantage plan, you're always a year behind, as you guys know, with the coding by the time the government catches up to it. So there's no, if there's a small number of patients, but the doctors are energized to do the right thing, it will be successful. Last year was obviously very, very challenging with the COVID and the election and this, but our Medicare Advantage plan in Palm Beach, actually, there was very little growth in the community, but ours had the highest number, more than the traditional ones. We had the most conversions into ours without more than any Humana or anything else in an HMO product in Palm Beach County. So we were actually number one, but we're also evolving. We didn't have dual eligibilities. We weren't allowed to have dual eligibility patients. So we were unable to take those. Now, next year, we will be able to do that. We are also with a deficit because it's very hard for a patient to switch to a plan that they don't have name recognition about. So hopefully now there's name recognition in the community, and you cannot advertise your new insurance plan until 10 days before you're allowed to enroll patients. So you're not allowed to advertise. So if we're starting, say in Georgia, and enrollment period is, October 14th, and we're ready to go and we're ready to start advertising. We're not allowed to advertise. We're not allowed to tell anything. We're not allowed to do anything until about 10 days before. So there's a lot of deficits to a new plan. Again, the barrier of entry to getting into this business is very, very hard. But we're excited in the prospects, and there's no doubt that an organized physician group will do the right thing to make it profitable and successful with a small number of patients and grow it. And our product now is, we're not looking to make money year one. We're looking to build name recognition and build a product that every patient that we have refers 5 more patients into the plan.
I have another question. I have an ACO patient and we have Advantage plan also. So you think I should encourage patient to go into Advantage plan or leave on the ACO?
Well, maybe save them until you open your own Advantage plan and then move them.
Go ahead, Dr. Parikh has a question. Go ahead.
Arthur,
Yes.
one question you can expound is a primary care physician, like-minded group of physicians, if they refer their patient to hospital-based specialty, such as cardiology, versus an independent physician, how much is the cost saving per patient?
So we're talking about what? We're talking about Medicare Advantage?
Medicare Advantage or ACO patient?
Okay, well,
Any Medicare patient.
And the facility fee, which
Yeah.
And how much is the saving per member,
Well-
per patient?
Well, so let's talk about this. Traditionally, if it's Medicare fee for service, everything outpatient is less expensive, substantially, because of the facility fees. Usually, a patient that is a Medicare patient that is part of an independent primary care practice versus a primary care doctor that is employed by a hospital is 30% more to the healthcare dollar. That's a fact. That's a fact. Thus, it's better to keep them on an outpatient. Now, there's exceptions. You may absolutely find a hospital employed surgeon that rocks and he gets it and he's value-based friendly. So there's no direct answer for that other than looking at the data aspect. Now, a Medicare Advantage plan, it's all contractual. We're saving sometimes right out of the gate. It depends on our contractual arrangement that we have with the hospital, with that surgeon's group that's part of the hospital.
Great, very good. So anybody on the system, just unmute yourself and ask question. You want to make sure everybody get all their question answered. And if you don't unmute and you don't ask question, that's totally fine with us. But let me tell you, I'm totally, go ahead. Hmm? Okay, so I think that 2 hand was raised, but I've been trying to get them into the system, but it looks like the hand is gone down, but they didn't tell us. One is Dr. Parikh and one is Dr. Trivedi. So if you're still there, please call. But this is a friendly place. We here to answer all your questions. So I am really, to me, I'm just trying to tell you, my dream is that get Dr. Hunt and Dr. Henson and Lori Lane to come to Georgia and bless her to create our Advantage Care plan. I know it's gonna be effort on our part. We created IPA. IPA purpose is to unite all our physicians together because there are, Georgia is a little bit different than Florida. Most of the physician are in some ICA, some IPA, and we basically creating this IPA where basically totally free, you can join us without any cost. And hopefully, I'm hoping that within about 6 months, we will have a critical mass in some of the county in Georgia for you to help us to create something extraordinary. I personally believe that I think we have a mission to take the healthcare from bureaucrat in our hand in the United States. We can do better job. We know what need to be done. There is no region for anybody else to do the healthcare except.
Dr. Desai, this for Dr. Henson, how much fund we require to start Advantage plan, initial fund?
Good question. Good question. So it depends of how long we want to do the actuaries for. So we're doing them for 5 years. And the biggest obstacle and the biggest expense is going to be the reserves. The amount of money that we need to put in the state treasury to pay the bills. So it's going to depend on the negotiations that we have with a strategic partner. It may be Prominence, it may be someone else. Since we feel we have a strategic partner with Prominence, we would consider that. We're looking where it appears that it would cost between 3 to 4 million per year to run, and the reserves have to be they're about 20% of the overall cost of that patient population. So if you are, that's when growth is a negative. So if you have growth and the growth is tremendous, 10,000 patients the first year, and maybe, it's, $100 million, you need to put $20 million within 30 days in the state treasury in a very fast part. So what we have with Prominence, we have up to $200 million in reserves, access to that money for the life of our plan. And hopefully after a few years, once we get positive, obviously we don't have to borrow the money from or use the money from the reserves. So
By that time, we'll have Arthur to fund us,
yeah,
By that
it's by that
time.
time. So it's a little tricky. Now I will tell you a fabulous story, and this is a very kind of sad story, but there was a beautiful company and HMO started here in Orlando. It was called PUP, P-U-P. And it was started by actually a cardiologist as well, and a few people and some investor money. They grew so fast one season. First few years there was stagnation. They got a trend. 1 year they were expecting 2,500 growth. They ended up getting 7,000 growth. They had to put in the reserves. They had to put in the reserves $11 million or $11 or $12 million. They were only budgeted to put half that money in. They went to go borrow the money. They were unable to borrow the money. They had to get the money in by 30 days. Day 31, the state came and closed them and gave all their patients to the other bigger companies. It's serious. And that's something that we learned. We knew about it. We visited it. We knew the owner well. And it was very, very scary for us to consider a plan without having deep pockets for the reserves, because that's a scenario that you cannot control. Because again, once the fuse gets lit in your community and the buzz gets lit and you guys are doing a great job after 2-3 years, you can have a tremendous unlimited amount of growth. And the government is making it lower cost for the patient to be part of a Medicare Advantage plan than to be in traditional Medicare. They first started that under Trump last year. So they're going to keep pushing that agenda. So it's going to encourage more patients to go into the Medicare Advantage plan. So we need to be smart about the reserves. That's the biggest obstacle.
Thank you.
Well, we're going 2 hours on this. This is awesome. Thank you very much, panelists, Dr. Hanson, Dr. Lane, Dr. Lou, and David, and Dr. Parikh. It's awesome. Thank you very well. This whole thing is recorded and will be available on Doctors SCO website. Thank you all. We will meet again and we'll do something good, something for common good. Thank you all.
Good night.
Thank you.
Thank
Good
you,
night.
guys.
Bye.